All right. Well, welcome everyone. I'm going to be the moderator for tonight's webinar, and I am Dr. Achenbach. I'm an associate professor of medicine and infectious diseases at Northwestern University in the Feinberg School of Medicine and also at Northwestern Medicine. My work has focused on working with individuals with HIV and different ways to optimize outcomes and improve health for those living long-term on antiretroviral therapy. So I am going to be our moderator, and we have two other experts here with us that will be really the experts guiding this discussion, who are both urologists who focus on different aspects of prostate cancer. So Dr. Amarasekera is, I'm going to call Dr. A because it's kind of a mouthful, just like my name, Dr. Achenbach. So he'll be the main Dr. A. He is an assistant professor of urology here at Northwestern's Feinberg School of Medicine, and he has a clinical and research focus on Peyronie's disease, erectile dysfunction, prostate cancer survivorship, and identifying and addressing urologic healthcare disparities faced by members of sexual minorities. So in addition to serving as an assistant professor at the Feinberg School of Medicine, Dr. A is the director of the Northwestern Medicine Gay and Bisexual Men's Urology Program, a newer program here at Northwestern that's been really exciting to get going. And then we also have Dr. Adam Murphy, who's on with us. So Dr. Murphy and I have worked together on some research on HIV-associated prostate cancer and outcomes here at Northwestern. But he's been studying health disparities faced by minorities in prostate cancer, including Black and Hispanic men, for many, many years now. Clinically, he's interested in general urology and men's health, and he has appointments at Northwestern Medicine, also at Cook County Health, Jesse Brown VA Medical Center. So he's all around the city here in Chicago. He's currently leading the Education Committee on Diversity, Equity, and Inclusion for the Cancer Prevention Clinical Trials Network for the National Institutes of Health. And he is Assistant Director for Community Outreach and Engagement for the Robert H. Lurie Comprehensive Cancer Center. So we have two really excellent experts in different areas here. So it's going to be interesting to see their different points of view. We also are really excited to have one panelist who's a patient. So we will be able to get the perspective not only from providers, but patients. And we have Bob Watkins here with us, who is a prostate cancer survivor. So there's Bob, who just waved. He's a 42-year-old resident of the Chicago area. And a recent retired healthcare administrator with a major regional hospital system. So Bob has been with his partner for the past 36 years and is an avid dog lover. What kind of dog do you have, Bob?
Come off mute for us.
Okay, I just thought I'd ask.
I'm sorry. I had a Shar-Pei. Those are my breed, Shar-Peis, but my last dog, she was only 4 years old. She had a sudden death about 6 months ago. So it's been tough. It's been tough.
Oh, that's tough. Well, I'm sorry to bring up a tough topic, but
that's okay.
But in terms of your prostate cancer, you've been a survivor. So he had localized prostate cancer in 2016 and was in the surveillance program for prostate cancer surveillance that he entered that same year. And then in about 2 years ago, in January of 2021, it was found to have ductal carcinoma, but then went through a successful radical prostatectomy 2 months later. So it'll be really interesting to hear your point of view as well, Bob, about all these different issues that we're going to discuss today relating to prostate cancer.
Thank you.
Welcome everyone, our experts and our experts both from medicine and as a patient. Okay, so before we get started here, I just want to ask that everyone remain on mute and hold questions until the designated Q&A session, which we'll have for about 20 to 30 minutes. So we should have plenty of time for that. And you can, along the way though, while the speakers are talking a little bit of their point of views, if a question comes up, go ahead and put it in the chat right away. If you want to write the question into the chat as things are going along, that's great. If you want to put it in there, then we have someone that'll kind of collate the questions and we'll go through them. Or if you want to come off mute and ask questions during the designated Q&A, I just ask that you wait until we get to that Q&A part to come off mute, just so we'd avoid any Zoom bombs or any interference with noises in the background. All right, so let's just start off a little bit with a couple questions for our providers. So for the urologists there, so Dr. A, so broadly speaking, what do you think the gaps are in care, and what's the state of research with regard to prostate cancer and gay and bisexual men?
Thanks, Dr. Achenbach. So I think, generally speaking, when you're looking at the gaps in care, you have to think about just overall LGBT health. And so a lot of these men who have prostate cancer or who are screening for prostate cancer grew up during the time of like an HIV epidemic. So they've already got some issues with trusting the system. And that can lead to some disparities in care, generally speaking. When you talk about prostate cancer and prostate cancer treatment, I think it's useful to think about screening, and then treatment or screening, diagnosis, treatment, and then the after effects of treatment. So in terms of screening, oftentimes PSA testing is used to test for prostate cancer or screen for prostate cancer. And there's some data that shows gay and bisexual men may be screened at lower rates, particularly African-American gay and bisexual men. So I think there are some screening disparities with African-American gay men and men with HIV. And then when you think about screening, there are a couple of barriers. There are a couple of areas that might be different for gay and bisexual men. So a PSA test in general can be a little tricky to interpret. It can be elevated for reasons outside of prostate cancer. So things like BPH or sexual activity, things like bike riding, any kind of physical activity that puts perineal pressure. But even things like ejaculation can cause the PSA to go up. In gay and bisexual men, something to consider is they might bottom, and if there's any trauma to the prostate immediately preceding, like in the 48 hours preceding your PSA test, that might lead to a false positive and biopsies that are unnecessary. So there's some issues with providers not thinking about this sort of thing, and there being unnecessary testing, unnecessary biopsies, and potentially overtreatment for cancers that didn't need to be treated. So that's the screening component. In terms of treatment or counseling patients who get diagnosed, there is generally speaking two types of treatment. I should say three. There's active surveillance, and there's surgery and radiation. And each comes with their own set of side effects and pros and cons. In terms of surgical counseling, oftentimes people forget that the prostate is a source of sexual pleasure for a lot of gay men. And so they're sort of blindsided by the loss of that sexual pleasure after a prostatectomy. In terms of radiation can often lead to rectal fibrosis, bleeding, and just irritation in the rectum, which can make it difficult for people who bottom. And then erectile dysfunction can happen with both. And oftentimes people don't really think about the fact that you need a firmer erection for receptive or for penetrative intercourse compared to vaginal sex. It's just, you just need to have a harder erection to penetrate the anus. So, the counseling, generally is geared towards heterosexual people, and that leads to some disparities in care. Yeah, I'd say generally speaking, those are probably, some high level areas where there are disparities.
Those are really great points, and a nice way to get things started. So I guess in contrast, Dr. Murphy, what are the gaps of care and the state of research with regard to prostate cancer and African-American men? What's the perspective from that angle?
It's interesting because I'm so used to talking about African-American kind of prostate cancer disparities and realizing that the disparities are actually worse on the gay and bisexual front in terms of the state of the research and the state of the knowledge, which is not good. African-Americans have the highest rates of prostate cancer in the world, along with Afro-Caribbean men. So 70% higher incidence rate. Dr. Achenbach and I looked at that, and it's still about the same. It's actually increasing in the HIV infected men as well, which is interesting. And then so for screening, Blacks and whites are very, very similar in terms of their rates of screening, but it's still under what's necessary. So it's about 38% of men on a given year will be screened. And there's good evidence now that Blacks should be screened every year even starting at age 40, that there's a survival benefit from the VA study, that if you got screened every year versus every other year or less, it actually improved the mortality rate of prostate cancer. So that's the screening part. And the treatment part, what Dr. Amarasekera is speaking to was very, very similar maybe 15 years ago in terms of kind of not understanding the treatment outcomes, not understanding kind of if the PSA levels were the same, if the biomarkers performed the same across race. A lot of that work has been done, fortunately, but there are still some issues in that if you look at, based off their risk factors, the National Comprehensive Cancer Network will kind of group people into 8 different risk groups for prostate cancer, from very low risk to metastatic. And from very low to high risk, the metastatic disease rate and the death rate is for Blacks still twice that of whites. So even at very low risk, Blacks still die twice as often with metastatic disease. And so I think what's more germane to our patient here is kind of the quality of the conversations that happen between doctors and patients. There's a lot of literature now showing that when you are racially discordant or culturally discordant, that the quality of the conversations go down in terms of the amount of education that goes on, in terms of the shared decision-making that goes on. Now, I actually know you two personally, you two doctors, and I love you both and know that you all do a good job of talking to people. So this is obviously not a universal thing, right? But there is this kind of diminished quality. And what I'm interested to hear Mr. Watkins talk to us about is kind of how that affected his decision-making in his course.
Yeah, so why don't we kick it over to you, Bob, and hear your perspective a little bit. So yeah, if you could kind of reflect upon that and how your interactions with providers may have impacted your different decisions, or I guess just kind of reflecting on two different aspects, both being Black and your sexual orientation, and how your experiences have been communicating with providers, and what things worked, what things didn't work, and I guess what has helped you in terms of making your decisions and thought process in your care.
Sure, no problem. Thank you very much. First of all, like I had mentioned earlier, I've been in the gay bisexual environment for most of my life, beginning in high school. In regards to my interaction with my physician, it's kind of interesting because it's both positive and disjointed. And I'd say that in 2 aspects. From the positive side, he's a very educated man. We work in the same system. I've known him for years. We're able to communicate. However, when the diagnosis of intraductal carcinoma was presented to me by him, it seems like it was much more based on theory versus based on how do you feel? What are some of the things you're going through, Bob? What is it that is bothering you? How is this going to impact your life? Those conversations did not occur. I sat in that chair after I got the shock of what I was up against. And my first question was, this is going to take away, a good stimulation for me that has been very important for me to the ejaculatory process. And I need to know how I'm going to mentally deal with this. And the response given, and I have a lot of respect for him, was, don't worry, Bob, your nerve endings will be intact, things will go well. That is the conversation that was given to me. When I left the office, I left a little bit bewildered. I left a little bit frustrated, but I left mainly because as a Black man, I couldn't sit there and say, look, man, I'm a gay man. I like to bottom. This is going to impact my sexual orientation and my sexual well-being. And I had no one to talk to. So I had to do my own homework and find out what I need to know. I asked my doctor right before I left, I said, I'd like to get a second opinion. He says, that's fine. He says, but you know, you have a type of cancer that can spread, and the sooner you get it taken care of, the better. I did get a second opinion. I went to a radiation oncologist. We spoke about some of the positive and the side effects of this type of treatment. I felt that would be an added burden onto already what I'm carrying right now to go through, you know, an extension of more pain, more erectile dysfunctioning, more just, you know, diarrhea, all the thing that goes along with radiation therapy. So when I left that office, I went home and cried and felt like no one could understand what I'm going through because I wasn't able to talk to anyone. And believe me, my doctor called me at home that night and said, are you doing okay, Bob? I said, yes, I am. But not once did I take the opportunity, because over my past 6 or 7 years with this physician, we never discussed my sexuality. He assumed that I was heterosexual, and this is the nature of the thing. So it was very, very difficult at that time. And I had no minority provider at that particular time that I could talk to. But most of all, I did not have the strength or the courage to talk to any of my fraternity brothers or other Black men about this, because I felt that everybody's in the heterosexual world. So it was quite dispiriting for me at that time.
Oh, wow. Yeah, it's really enlightening to hear your point of view and just kind of hear from you how you were feeling at that time. I guess for our two urologists, the two doctors, I guess, speaking to Bob's points there, what kind of things do you guys think about? What kind of considerations do you make when you have patients that are Black and or gay and bisexual men? I guess what kind of resources or strategies do you guys utilize to ensure that, I guess, what happened to Bob maybe doesn't happen again, and that we can try to give more information and make sure we understand the patient perspective from all angles?
Dr. A, you want to go first?
Sure, I'll go first. So one of the first things we do in clinic is to obtain some general basic demographics information, and with that, some sexual orientation and gender identity data. Just having that as a box you can check, I think, takes the responsibility away from like the patient to tell you, and some physicians may not feel comfortable, you know, asking. So it makes it a lot easier, I think, for other doctors to ask if that's not something that's routinely part of their practice. So I think, you know, you can, if people feel comfortable enough, they can check those boxes. So in the way things are practiced now, and hopefully in every office now, someone like Bob who comes in, the doctor would know that he's gay, and like you should counsel this patient differently than you would in a heterosexual patient. So that's been a nice change, I think, systemically within the Northwestern system, at least, to allow providers to sort of broach a conversation that may otherwise not have happened. That said, if patients don't check that box, I still you know, educate people that it's really the doctor's responsibility to bring that up, because you should let the patient know that you're open to talking about this. And if the patient doesn't want to talk about it, then that's fine. But I think the onus is really on the doctor. That is one of the ways we, you know, sort of avoid what happened there. But also, as soon as you get a prostate cancer diagnosis, we do give people a booklet geared towards gay and bisexual men that we, you know, made so that the areas of concern that are, you know, specifically relevant to gay and bisexual men are highlighted within this booklet, and they can spend maybe half an hour to 45 minutes reading about it. And the next time they see you, they have the chance to ask you more informed questions.
I'm curious, you said they fill out or do a check mark. What are the questions that are asked?
Yeah, so there's a box that you check now that will ask you what your gender identity is. So if it's male, female, non-binary, or, you know, whatever it is, there are several choices. And then you can put your sexual orientation in now. So you can say you're gay, bisexual, pansexual, omnisexual, in a variety of different options. And you can do that online, but we've also started giving people paper handouts when they check in.
Is this for every physician in the system or just for urology?
The paper one is just for my clinic, just because it's we haven't got every physician in the system to adopt a paper form, but the system we use system-wide is called Epic, and it's just the health record system, and they now allow all patients to identify their gender and sexual orientation.
Okay.
Yeah, and there's much more of a push utilizing Epic for what we call like patient-centered surveys and collection of information. Not everyone really wants to fill out a long, lengthy survey every time they go see the doctor, but there's a subset of people that might. And so we're in a lot of different areas in different clinics. There's a push to trying to get more, making things more patient-centered and getting more information directly from patients, as opposed to having a provider or a medical assistant go in and always asking all the questions. Know what I mean?
Well, also, that's great through Northwestern, but what happens to, I'm in a situation where I'm at a white-oriented type of medical system where everything is assumed that this is who you are. And I think about that. I'm very educated on this stuff, and my physician is very educated. But the problem is, if I would have known, if I could have said that day and said, look, how am I going to deal with the loss of my prostate, which is the most important thing to me from a sexual aspect, because I bottom. I said, that is part of the relationship. I was too embarrassed to say that because I was afraid of the response. And many Black men are in the same boat. They're afraid to bring that up, especially Black gay men, because of the stigmatism that surrounds those conversations. Because the first thing that happens, there's a bubble that goes around the conversation. And all of a sudden, the defense mechanisms begin to set in. And pretty soon, the object of support to help that person becomes a rejection of that person. And that is so, so obvious to me.
I think you're saying that the providers have to be ready for
Yes.
the outcome of the survey and
Yes.
that information. And I think that I'll ask this interject this question for Dr. Amarasekera. There are people who will say that they can offend other patients by asking about people's sexual orientation, sexual behaviors, in systems that are more we assume are more homogenous in terms of sexual orientation. What do you say to that? How do we get around that?
Yeah, so they've done some research on this, at least here within the system at Northwestern, but I think there's actually research on this outside of our system too, and there's really not a lot of offense caused by asking the question. Maybe 20 years ago things would have been different, but I think there's been sort of a sea change in public opinion about LGBT people in general. We're obviously nowhere near where we need to be, but getting asked that question, I don't think is seen as an insult. I think that's probably, I don't know what, I mean, my prejudices say it's probably people who've trained in the distant past who feel that way, but generally speaking, I think people are pretty comfortable being asked that question.
I mean, I still get some patients that kind of seem taken aback by the question, but I think that the minority, I think that those folks are a minority compared to the amount of gay and bisexual people who are in the community. So I think the benefit is towards asking for sure.
Sure. There are occasionally people who are taken aback, and then I tell them, listen, these are questions I ask everybody. It's, we're not making any judgments on anyone. And these are just, questions I ask of all patients to normalize it.
I think one of the things that did help me during my process and my journey, the practice had the opportunity to have a sexual men's health educator there. And he was he was gay. So it made life a little bit easier to deal with because I was able to express in terms that he understood and accepted. And I could see that by the expression on his face. His facial expression told me that this is safe. Talk, let's talk. And that made a big, big difference. And to me, I was able to bring those things out. He in turn was able to kind of share some of that. And I told him I wanted to have a safe area with my urologist to somewhat, so we could at least understand where I was coming from. And when I went back to my urologist after speaking with the health educator, the conversation was much more amenable in terms of understanding and, process. And I think he understood where I was coming from. I was not able to communicate my sexual orientation like I wanted to with my urologist. I wasn't able to say, look, man, taking my prostate away is taking half of my manhood, period. That's what's going on.
So, Bob, how did you find that educator? Were you referred to that person, or did you seek them out in the community? Kind of find them in the community, or how did that work out?
The practice has a
they did.
men's
Okay.
health educator that works with prostate cancer patients.
Got it. Okay. Oh, but that's good. It's a good resource to know about.
I actually don't think that patient.
And Adam, do you have kind of more? Do you have specific resources like that for Black men as well? I guess what kind of strategies or things do you think about, in that group?
There are resources for. I would say it this way: the NCCN and other groups like Prostate Cancer Foundation, Zero Prostate Cancer, they have information for Blacks and the American Cancer Society, but it's not as patient-centered in that it's not told from the perspective of what Black patients consider should happen to them, right? Like it's definitely the epidemiology is in that data, kind of the enhanced risk in that community, but not necessarily kind of experiences from Black patients. What my strategy has been, and I love the booklet idea that Dr. Amarasekera has come up with. Basically, my strategy has been to slow down the decision-making process, even through people who have unfavorable intermediate risk prostate cancer, because what I realized was when we did this clinical trial, we slowed down the treatment decision for prostate cancer by 2 weeks, but that increased the uptake of active surveillance to 80% of our population versus 40% in the country. So I think there's something special about slowing down the decision, and the impact that we had on our treatment decision test we were doing, which was a genomics assay, was in men who had low health literacy. So I think those people actually kind of responded to the data that we gave them more strongly. So I think that one thing I've been doing is, okay, you get the diagnosis. I see a lot of kind of big eyes, and you can tell when people are kind of glazing over in the conversations and not really able to process more information. And so I typically do this thing where they come back in a few weeks to have a second discussion. I tell them to invite family members, partners, daughters, a lot, but sometimes it's partners or male friends and supports who will come back and help remember the details of what we're saying to allow them to have another kind of ear to bounce information off of. It also gives people time to gather information about their family history, because they'll find out that an aunt or an uncle had prostate cancer that they never knew about, because cancer diagnosis is stigmatizing in the Black community and not well discussed. And so they come back more, I think, more ready to engage. And I give them the NCCN's prostate cancer guidelines for patients, which is at one level of, I think it's at 8th grade reading level, 8th to 10th grade reading level. I give them this one booklet that's old, that's a Crane's publication, that's about 8 pages, and it's a little bit more basic. And so I give them both. So I tell people, read the easy one first, then if you feel comfortable, dig into the NCC Insight more.
Well, I think going back to communication, something that occurred too, as far as communicating with my partner, I noticed that communicating with your doctor, with your partner, I wanted that to happen, but I had to do what's called the fake road. I had to say, I'll talk this with my brother or my cousin or my friend. I couldn't come out and say, I want to discuss this with my partner, because I'm going to tell you why, because I had not had the stage prepared for me previously to be able to step on that stage and feel comfortable in bringing my partner into that conversation, because based on, once again, the stigma of the practice, and it wasn't a bad stigma, don't get me wrong, it just, I felt they would be uncomfortable trying to deal with this. Seriously, that's just how I felt. So when I had surgery that day, the first thing he said, well, you know, Bob, you're going to be going to surgery. Do you have any family here with you? I said, no, most of my family is at home in Kansas City. I said, but I brought a good friend with me, because I could not say he was my partner, because at that point, I wasn't sure how the rest of that medical surgical team was going to react. And I was concerned about getting the proper care and the right surgery to make sure things went well. My fear level had blocked out my ability to be upfront.
I had a patient recently, I want to see if you agree with this. He's a friend, actually. He had prostate cancer treatment in Chicago at one of our major centers. And he had his prostate removed.
Mm-hmm.
And after they took the catheter out, he had immediate erections. And he called his doctor nervous and upset, because he thought the doctor did not do the surgery. He thought that he had a sham surgery. And they did not do a full surgery, because this should not be happening from what he had read online. And so that, to me, spoke to the level of medical mistrust that this person had in the healthcare system. Is it to that degree? Obviously, you knew your doctor well before.
Mm-hmm.
It seems like that's kind of what you're intimating. That
Yes, pretty much so. And it was not. It was. I considered my doctor for all those years my friend, but I considered him a distant friend, a friend professionally. But what I needed right there was a friend to understand me. And I wasn't going to get that, because this man was ready to put me under, put up the Da Vinci machine, go in there and remove my prostate. And I wanted to make sure that it was done right. So, I even asked the folks in anesthesia, I said, how long can you keep me awake? Of course, I fell asleep right after that, it was, but I was just concerned that, but I felt I left my friend, my partner out, because he wasn't there to support me when I needed that support, because the physician and the medical team, who were great, professional, outstanding, I just felt they wouldn't be acceptable to it. That's just the way I felt, and that's the truth.
And did all that impact your relationship with your partner, or even just having cancer and the treatment? How did that impact your relationship?
Yes, it did. It made it difficult after that to kind of explain the whole process, because even though I'm very educated and knowledgeable, I really needed for the physician to sit down and explain to him step by step exactly what occurred and why and so forth. I could do that, but I wasn't able to bring my partner there so he could be there not only as a support mechanism, but to be there as someone who wanted to learn about prostate cancer, being a Black man, the same age that I am, going through some of the same things. And it was, I wouldn't say it was so much mistrust. I would probably say it was misguidance, is how I would look at it. Because I had the trust of the professional team skill-wise, but I didn't have that trust of openness to explain who I am. And that was also impacting my ability to recuperate well, because that became a hindrance in recuperation, because I felt like, feeling so down and so forth, that my body, my immune system, started kind of getting a little bit worse. It just all went downhill. I had to go back and, we had to regroup some things and so forth. And I think if I had that education from that physician who was able to say, Bob, you're going to lose your prostate. I know it's going to affect your sex life. Life will go on. You will be able to have a good sex life. You just won't be able to have the point of climax. But believe me, you can do that. And your partner and you all can enjoy each other. If he could have said that, this would have been a breeze operation. But that did not occur. And in the Black community, that's what's happening. The Black men, gay Black men, have a real difficult problem dealing with it. But Black straight men also have a difficult problem dealing with the same thing.
Bob,
Those are really terrific insights. Yeah. Dr. A, go ahead.
I think you bring up some excellent points. I mean, I think anyone who deals with prostate cancer, any urologist who helps patients with prostate cancer, if your patient is non-heterosexual or heterosexual, I think they should just ask you who your support system is, or like, is it a partner, is it a friend, is it more than one partner, and not make any assumptions, because there's higher rates of non-monogamy for gay men in general, and I think a lot of assumptions are made for gay men, and a lot of I guess like the relationship dynamics are missed. So I might seem pretty straight-laced when you talk to me, but in the patient encounter, we get down to the nitty-gritty. I mean, we talk about everything,
which is good.
Right. I am now Bob's co-urologist, so Bob can probably speak to that better than I do.
You got to get into the details to really know where the patient's coming from. I mean, that's really what it boils down to. It's spending time with them. Okay, shifting gears really quick. Last topic before we open it up to Q&A is more on, I guess, kind of the future, like looking ahead. Dr. A and Murphy, I guess, what kind of things do you think we need? What kind of research interventions? What's going to help us improve outcomes and just this general issue that we've been talking about? How can we do a better job? Essentially, what do we need to do that?
Adam, are you okay if I go first again?
I am A-okay.
Great. I mean, I think there are some very basic things that need to be changed. So like even now, when someone comes in after prostate cancer, or just in general, if a gay man comes in, the only tool we have to measure sexual function is a tool that measures erectile function. And that's obviously not appropriate for a lot of patients, and it may or may not matter to someone who bottoms, but certainly that's not the whole experience. So we miss the opportunity to capture data and track these patients over time if we don't ask them about other aspects of sexual function or other sexual practices they might engage in. So that's just like a very simple thing that I think needs to be changed, but it takes a while to validate these new questionnaires, and it's a little more complicated, but we're getting there.
When you say bottom, what are you talking about, Dr. A?
So right now you can ask someone on a scale of 0 to 10, how firm is your erection? That's a way you measure erectile function for someone who has, penetrative vaginal or anal intercourse. But if you take the prostate out, then the intensity of the experience, or like the pleasure associated with the experience, might diminish. So there's got to be a better way to measure that, because right now that's not being asked at all. So you can sort of track that over time. If for nothing but getting that data and trying to figure out what the experience is for people. so that's one area that I think might need some, definitely needs some work. The other thing I think that gets overlooked is like our biggest asset is the like gay and bisexual community. Just generally, when you think back to like, I keep thinking back to the HIV epidemic, and like the community was its own advocate. And so having a network of other, gay and bisexual men with prostate cancer sort of available to newly diagnosed patients, I think is key. We just don't have that network just yet.
I just think about this from the, you and I got to do research together. At least we got to write a grant together about how little is known in this space, right? And as a urologist who I told Mr. Watkins that I consider myself an ally, right? There's aspects of gay and bisexual men's sexual behaviors, relationship structures, changes in and after cancer that I hadn't ever heard about in medical school, hadn't heard about it in residency training. I had to read blogs to kind of get caught up to where you, from being a provider in the community, to that community, kind of just know, right? Are there things that urologists should be reading to kind of have a better sense of kind of having these conversations? I think the person who Mr. Watkins went to as a provider is actually an ally as well, and would have been, in my mind, comfortable with the conversations. But I think making sure that we know how to bring it up, and also kind of being ready with the right answers and resources is kind of, I think, a key part of that. I want to hear you talk about that, kind of.
Yeah, so right now we're writing some chapters in textbooks about what the differences are for gay and bisexual men with prostate cancer. So hopefully, as the curriculum kind of catches up to what the needs are and sort of changes over time.
Those are for medical students or residents, or what's the audience for that?
Yeah, this is for essentially anyone, but
Anyone,
our book is aimed at both patients and providers. So there's a book by Patrick Walsh, and that a lot of patients read. And there's a chapter now in the latest edition that'll be published pretty soon. A whole chapter for gay and bisexual men about what's different, what you should be asking your providers about. And then we've been presenting our data at the AUA, like the annual Urologic Association meeting, and educating providers that way, but also through the AUA with like classes that Adam and I put together last year about diversity and what that means and what's different for LGBT folks.
Great. All right, Bob, one last thing for you. How about what advice, I guess, would you have? So we'll kind of end our initial part here and turn to our Q&A and talk to our participants here. But I guess what advice would you have for other gay men who might be going through this, who might be going through prostate cancer diagnosis and treatment and all that? And along those same lines, if you could go back in time and do anything different, what would you have done differently?
Well, if I could go back in time, if I could have found a Dr. A, I would have been very satisfied. But since at that time he wasn't there, back then, probably what I would have done, and Dr. Murphy, you're correct, our ally over there, our good friend, probably would have understood and probably would have discussed it. But at that point, I did not see any indication of that. And that's what kept me from opening up to him. And I believe me, I've opened up to him about a lot of other things. And secondly, I was in a professional relationship as well because I worked at the same facility. And, I had to also look at, and believe me, no confidentiality was broken, but in my mind, I was real careful on how and what I said, because that's where I worked at. That was my livelihood. So yeah. I wanted to make sure, and that may sound strange, but many Black and gay men feel the same way. They're not going to say things because they don't want it to jeopardize their relationship with their buddies, their relationship with their spouse or partner, and their whole relationship with their livelihood, because they're afraid if this gets out, what are they going to say? Many, many things. But if I could turn the clock back, I would have been straightforward, laid it on the line and say, here are my feelings. What's going to happen when you take out my prostate? How am I going to satisfy? How am I going to be satisfied? And what obstacles am I going to run into? But most of all, will this cancer come back? And that's a question that many, many, many Black and gay men worried about. They figure that once the prostate is taken out, they're good to go. That's not always the truth. And that's where education needs to happen, because I read up on it. I said, now, how quickly can this come back? I looked at my PSA for the first 6 to 9 months. It was undetectable. It wasn't there. But I kept saying I had ductal carcinoma, which is a little bit different than having regular prostate cancer. And it was inside those ducts. And I asked my provider, did you get everything when you went in there with that machine and picked up everything? He says, yes. I said, well, I hope so, because, I don't want to go through this again. But I would have been probably more open, and I probably would have looked for a Black physician that I could talk straight face to face with. And that's not to say no prejudice. It's just my comfort level would have been a lot better.
Thank you for that.
Excellent. Those are great ideas. Thanks for the advice to everyone. All right. So switching over to our Q&A part, and anyone can feel free to jump off or come off mute and ask questions, but there's a couple quick ones I think we can do that are in the chat that I think are really good questions that probably we all have. First one is for Dr. A. Is there a correlation between bottoming and prostate cancer?
So no correlation between bottoming and prostate cancer. There's been a study looking at HPV risk or people with HPV and whether that leads to prostate cancer or like a history of STIs in the rectum. You might think inflammation in that area might lead to prostate cancer, but there has not been a correlation. But people often ask, I think a couple of common questions people ask are, does bottoming lead to prostate cancer? And the answer is no, but it can lead to a diagnosis that may not otherwise happen because your PSA was just elevated because you just bottomed.
So kind of like a false positive maybe on the PSA.
Right, exactly. Any other thing, particularly gay couples or someone, might ask about is, can I give my partner prostate cancer? And the answer is no, but that's something that people often ask.
Okay, another quick one for either of you. Is it safe to bottom when one has BPH? So we didn't really talk too much about BPH. This is more of prostate cancer, but a good question.
Yeah, absolutely. Totally safe to bottom with BPH. Sometimes, if you have trouble peeing after bottoming and you have really terrible BPH, that may be a sign that you need to see a urologist to address the voiding issues that you have, like the pre-existing voiding issues, but totally safe to bottom with BPH.
Okay, great. Another one for you, Dr. A, about the booklet. There's a question, is the booklet you provide to gay patients something you can make available to us?
Yeah, absolutely.
This participants in a support group, I guess, and sounds like would be willing to share that with others.
Yeah, we have an electronic version, which we can share with the group here.
Excellent. Okay, let me see. What else? What other quick ones do we have? Okay, looks like Adam, Dr. Murphy had a little side conversation. Good, okay. There's just I don't see any other questions there in the chat, but there's one more here at the bottom here of our chat here. So how often should one be checked if on active surveillance? So I guess kind of like Bob back in 2016, when he had the early stage cancer, he was in an active surveillance program, correct? And so I guess how often, Bob, were you needing to come in, or for the urologist, how often do you keep an eye on that?
I was in the program when I was first diagnosed, and I had a biopsy every 6 months, but we also had what was called active surveillance meetings once a month, where members who were part of the surveillance program, we would get together once a month to talk about what's going on, to be able to discuss these things. It made a big difference. And every 6 months when I went for that biopsy was an indicator to my urologist based on, how many screens of biopsy they took and so forth to determine how my cancer was progressing, whether if it was increasing or decreasing or remaining the same. And my big question that I had when I was diagnosed with that ductal carcinoma is, how in the world did I get it? I thought we were doing all this surveillance, and why wasn't it picked up? And the answer was given to me was, Bob, there's not really a good answer. It just happened like that. And that kind of left me bewildered, because I did all this surveillance every 6 months religiously, even changed my nutrition habit to eat better. And yet and still, all of a sudden, here comes something that I was not expecting. And my urologist said, I wasn't sure myself, Bob. That's why we sent it to Johns Hopkins to make sure that we got a good second opinion. And it was ductal cancer. And, it's just something that happened. But also, I need to also back up a little bit. And we felt that some of that could have been because I was getting testosterone treatment because my testosterone was low. So that could have impacted something. They felt that because of the testosterone being low, and once the testosterone increased, it increased the cancer growth possibility. So there were many, many things.
Can I say a couple things about what you just said? One of them is that the protocol for active surveillance has changed a lot since when you first kind of got diagnosed. And what they were using at your system was more similar to what the Johns Hopkins people did at the beginning of active surveillance, with much more frequent prostate biopsies, very close PSA watches, right?
Yeah. Yes.
Now the NCCN, the National Comprehensive Cancer Network, and American Urological Association has eased it up some, where you can do PSAs every 6 months, rectal exams every year. And then there's a lot of variation still in the frequency of the biopsies, but you would do at least one in the first year, and then you can vary them 1 to even 3 or 4 years between them, because now people are using MRIs and genomic testing to see kind of your risk. There's other ways of measuring risk besides the biopsy.
That's true.
There are still urologists who still will adhere to this every year. There are some that are very liberal and make them every 3 years after the first one. So just for the people in the audience, there's variation. I wouldn't expect people to do as rigorous an active surveillance protocol as you've had. But I think that the thinking about active surveillance that is sometimes missed on patients, because there's a need when you get a cancer diagnosis to actually deal with some of the anxiety. And so you have this sense where, okay, I think this is a safe cancer. So but key to active surveillance is the idea that we're catching progression happening with those biopsies. So the fact that they're doing the biopsies is because there's an expectation that this cancer can get worse, and in fact, does often get worse. Now, people can last on, if they're white, about 10 years, if they're Black, about 5 years without progressing. But still, the progression is towards worse disease.
That's very true. And the doctor told me that, and our active surveillance was not only about nutrition and so forth, it was also about support, able to really talk about what was going on, to share some of our experiences, what we were going through. And the group was mixed. It had a few Black men in there, Oriental, white, etc. But it was mixed, but I was probably the only gay Black man in there based on my assumption. I could have been wrong, but based on my assumption. And also the support group, the group wives were invited to attend as well. And my thing was I wanted to bring my partner, but I felt uncomfortable bringing him there because I did not know how the rest of the group would respond. Once again, that fear of rejection coming along with just the stigma of who I am really made it difficult for me sometimes to really feel comfortable even in that active surveillance group. We talked about the cancer growth and how the purpose of this is to maintain, as you said, do your PSA, your rectal exams and so forth, but just to be able to discuss and talk was very, very helpful. So yeah, pros and cons.
In their surveillance, do you ever take into consideration any of the factors related to race or sexual orientation? Is that not generally part of the surveillance?
People were initially reluctant to do active surveillance on Blacks, but it caught up a lot in the last 10 years.
That's improved,
I don't know about is there any data on gay and bisexual men having under selection of surveillance?
Under surveillance, or under screening, I suppose, could be another way of thinking of it.
Right. There's no data, as far as I know, about differences in like active surveillance uptake in based on sexual orientation. I have to say, in my practice, I generally get a biopsy and then get subgenomic testing, get another biopsy within a year, and then depending on how aggressive things are on genomic testing, we come up with our schedule. So it's still pretty variable and personalized. It depends on what the patient's risks are.
Okay, great. There was one more question in the chat, but I think Adam answered it, but Dr. Murphy answered it. But after a prostate biopsy, how long can you expect to see blood in the semen and urine? I just opening this to the group because others might have this question. And Dr. Murphy, you answered it could be anywhere from 3 days to 3 weeks. So that's quite a wide range. Sounds like, but
it is. I call the prostate like a sewer system with a lot of ducts. And because it's like a sewer system, the blood from the needle, when you put the needle in the prostate, can kind of spread throughout the prostate. And depending on how sexually active someone is after that week is over, they may get rid of that blood faster than others. Then just in the randomness of biopsies, like when you get a blood draw, you may bleed after that stick or you may not a lot, So I think that's why some of the variation that. And then people are on aspirin, and people sometimes don't listen to their doctors and persist to have sex too soon or do some heavy lifting too soon and end up with extra bleeding.
Yeah, that bleeding, I will say that, yes, I experienced that numerous times, and it varied based on, the biopsy. The first time I had it, it was like, I was having a eruption of blood coming out of there. It was like it was going on for a whole week and a half. Then the second time I had it, it wasn't as bad. And as I got more and more, it seemed to get less and less, but the bleeding was there. And you're right, even during masturbation, that blood was very obvious too, which is frightening also because you have blood coming out when you're having both an orgasm and blood at the same time. It's kind of mind-boggling.
Yeah, sounds scary. Did you get warned? Were you warned about it? Your providers, do you feel like they adequately addressed some of those issues?
Yeah, he addressed it. Of course, I called him, and he said, Bob, he was so good. He says, first of all, slow down on the hand action. And secondly, that's going to happen. If it continues, you have pain, fever, etc., you need to get into the emergency room immediately. He says, but monitor it. And he says, drink plenty of fluids. He did stress that. He says, and let it just rinse itself out. Just like Dr. Murphy said, it was like a sewer system. He had to clean up all that stuff in there and get it out of there.
So, climacturia, depending on how profound it is, I guess, like the first line I tell patients is, try a cock ring, just like a standard, like a penile constriction device, which can often provide enough pressure on the urethra so that you don't have like spillage of urine. So that's a first line of therapy, I think. And also peeing before any kind of sexual activity, so your bladder is totally empty before you start. Those are, a couple of, things to start with. You're right about the penile implant. You can, just having the penile implant can put a lot of pressure on the urethra and can often help with any kind of incontinence during sex. But there's also like adjunctive procedures during the implant where people can put like a little sling or a little mesh that compresses the urethra when the implant is pumped out. So that's an option, but I mean, obviously if you're having really good erections, probably not there yet, or not necessary at this point. But it's a really difficult, problem to address. There's not great solutions outside of, what I discussed other than the sphincter.
Okay, well, I think we're kind of out of time and we're going to wrap things up, but I really wanted to give a strong thank you to Bob. Bob, thanks so much for you jumping on and telling us your personal story and, being vulnerable, personal with us. So we really appreciate that. We can't get better as providers unless we have patients helping us and giving us that type of feedback. So we really appreciate you.
Thank you.
And I just wanted to thank Dr. A and Dr. Murphy for inviting me to moderate, and thank everyone else. And I think, Dr. A, were there some closing comments you wanted to make about your research program?
Well, I think Adam took care of that for me. Thank you, Adam.
Okay.
So we are doing research here at the department in terms of better outcomes for gay and bisexual men or LGBT people when it comes to urologic care. Rahul Prabhu, who's on the call, Rahul, if you want to wave, he's our fantastic research coordinator. He'll be emailing everyone after this with ways to get involved.
We really appreciate it. We can't do anything without getting your feedback and volunteering for our research and our clinical studies and all that. Oftentimes they're low risk, easy things to do. Surveys, we just need more information. So we always need help with participants in research. So thanks so much. And thanks to everyone for joining our webinar and taking the time to discuss these really important issues. We appreciate it. Thank you.
Thank you. Take care.
Thank you, everybody.
Bye.
Good night.
Good night.